Hello everyone, now we'll discuss about malignant melanoma. It arises primarily from melanocytes at the epidermal dermal junction but can also originate from the mucosal surfaces. Example, the oropharynx, nasopharynx, eyes, proximal esophagus, anorectum, leptomeninges and female genitalia. Melanoma is an ectodermal neural crest derived malignant tumor arising from epidermal melanocytes. It is the most aggressive form of the cutaneous malignant tumors. It has a burden of less than 2% of all skin cancers but can cause vast majority of cancer related deaths. It is the fifth most common cause cancer in the US. Approximately 1 in 6 cases occur in patients under 45. Geographically, it is mostly seen in America, Europe, New Zealand and Australia. Lifetime risk is 1 in 20 by the age 74 in high incidence regions. Genetics, approximately 10% are gene positive with a link to the CDKN2A variants. Dysplastic Never syndrome heightens baseline risk. Xeroderma pigmentosum increases risk by 1000-fold. The UV and phenotype risk matrix. High risk phenotype. Fair skin, blonde or red skin, blue eyes, poor tanning, high count of melanocytic or dysplastic nevi, approximately 6 to 15 mm. The UVA exposure, longer wavelength, deeper penetration, predominant in tanning beds, linked to melanoma even without sunburns. UVB exposure causes direct superficial burns. Severe blistering childhood burns sharply escalate lifetime risk. Melanoma displays one of the highest mutational burdens of any human malignancy. Progressive oncogenesis is characterized into 4 genomic drivers. The genomic driver matrix, the BRFA mutant, RAS mutant, NF1 mutant, triple wild type, WT, BRFA mutant. In approximately 50% of the cases, it is the most common cause. It is usually seen in typically younger patients. Primary mutations are BRAF V600E followed by BRAF V600K. RAS mutant. It is seen in approximately 30% of the cases. The second most frequent genomic driver. NF1 mutant. It is seen in approximately 15% of the cases, typically seen in older patient demographics. The triple wild type, it comprises remainder of the cases, the lack of BRAF, RAS and NF mutations displays the lowest rate of UV signature genetic changes. The molecular signaling pathway, the extracellular signals or the growth factors. There are two pathways, the MAPK pathway and the MI3K pathway. The MAPK pathway is also known as the primary survivor or the proliferation pathway. It happens because of gain of function of the BRAF or the RAS gene and loss of function of the inhibitor NF1, which leaves this constitutively active. In the PI3K or the AKT, it drives proliferation via the mTOR. There is frequently altered across all subtypes via the loss of P10 chromosome. 10 the tumor suppressor in 20 to 25 to 50% of the sporadic cases. The PI3K acts on the AKT, which acts on the mTOR, which causes the cell proliferation. The cell cycle regular bypass. Loss of CDKN2A prevents normal inhibition of the CDK4, allowing cells to bypass the G1 by S phase with checkpoint and replicate uncontrollably. The clinical evaluation of malignant melanoma is by the ABCDE, where A stands for asymmetry. One half of the lesion does not match the other half. B is irregular borders. Edges are notched, dragged, blurred, or poorly defined. C is color variation. Pigmentation is not uniform, contains shades of brown, black, tan, pink, or the blue. D is diameter, which is more than 6 mm. The size is typically larger than a pencil eraser. Through smaller melanoma can occur. E is evolution. Any noticeable change in size, shape, color or symptoms like itching or bleeding over time are noted. Early melanomas can mimic benign seborrheic keratosis, waxy raised, stuck-on look, and vice versa. Comprehensive full-body skin exams are mandatory. The other clinical subtype of the malignant melanoma are the superficial spreading, which is most common in 70%. It has a variegated, irregular look, prominent radical growth phase before the vertical phase. It is mostly noted in black of the men. In women, it is noted in the legs. Better prognosis if caught early. In the nodular melanoma, it is 12 to 25%. More aggressive, lacks a significant radial phase and displays rapid vertical growth, commonly appears de novo. It is noted on the trunk, head and neck, mostly in the men, and has a poor prognosis. Lendigo maligna is noted in 7 to 15% of the people. It is the least malignant, slow growing, variegated brown macule or the lentigo in situ type. It is noted on the face, neck and hands of the elderly woman. Acral lentiginous. It is noted approximately in 5%. It occurs at flat, irregular macules or nodular regions, frequently misdiagnosed as fungal infections. It is noted at palm, soles, subungual region, common in Asian, African or the worst prognosis. Amelanotic melanoma, it is rare. It lacks melanin pigment due to cell undifferentiation. Presents as a progression pinkish fleshy tumor. It mimics soft tissue sarcomas, requires markers like S100, HMB4S to diagnose. The desmoplastic, the special type of the form, it is found on head and neck, strongly propensity for perineural infiltration, often clinically amelanocytic, and has high local recurrence risk. The prognostic modifiers are the ulceration, mitotic rate, and tumor infiltrating lymphocytes. Ulceration, the absence of an intact epidermis, an independent adverse factor that automatically upstages disease or worsens prognosis across all T classification. The mitotic rates, mitosis per millimeter square, a key survival predictor, then heavily influences SLN biopsy decisions in thin 0.8 to 1 mm lesions. In tumor infiltrating lymphocytes, it correlates with a more favorable immune response and clinical outcome. The historic Clark level of invasion, anatomical skin layer depth has been supplanted by the Burslow thickness, which measures the actual vertical thickness of the tumor in millimeter from the top of the granular layer to the deepest tumor cell. The thin melanoma is less than 1 mm, intermediate melanoma is the 1 to 4 mm, and the thick melanoma is more than 4 mm. The AJCC TNM classification: primary tumor T1 is less than 1 mm, A is less than 0.8 mm and has no ulceration, B is 0.8 to 1 mm with no ulceration or less than mm with ulceration. T2 is 1 to 2 mm in which A has no ulceration, B is with ulceration. T3 is 2 to 4 mm, A is no ulceration, B is with ulceration. T4 is more than 4 mm, A is no ulceration, B is with ulceration. Regional nodes N0 is no node involvement, N1 is one node involvement, A is micrometastasis, B is macrometastasis, C is satellite or in-transit lesion pattern, N2 is 2 or 3 nodes involved, N3 is more than 3 nodes involved, matted nodes or clinical nodes with satellite or in-transit metastasis. Distance metastasis M1A, skin, subcutaneous or the distant lymph node metastasis with normal LDH. M1B, lung metastasis, it has normal LDH. M1C, other visceral or the distant metastasis, elevated LDH is noted. M1D is brain metastasis. The staging: stage 0, the tumor in situ, melanoma in situ, N0 M0. Stage 1 is T1 T2A N0 M0. Stage 2 is T2B T4B, N0, M0. Stage 3 is any T more than N1, M0. Regional node positive. Stage 4 is any T, any N, M1. Distance metastasis positive. The disease dissemination, local, regional and the distant spread. It spreads to regional lymph nodes via the permeation or embolization. The locoregional end-stage definition, satellite nodules, secondary nodules within 2 centimeters of the primary tumor. Intransient nodules, they are skin or the subcutaneous nodules more than 2 centimeters from the primary tumor but trapped before the regional lymph node basin. Occult versus the apparent. Occult are identified via the sentinel lymph node biopsy versus apparent are identified by the clinical imaging and the needle biopsy. Definitive local control biopsy and the wide local excision. Biopsy protocol, excision biopsy 1 to 3 narrow margins is ideal. Incision or punch biopsy is reserved for large or difficult sites. Must contain full thickness plus normal adjacent skin to assess depth. The margins that can be excised. For in situ tumors, 0.5 to 1 centimeter is the margin. For thin, that is less than 1 mm depth, 1 centimeter is the margin. Intermediate, 1 to 2 mm size, 1 to 2 centimeters is the margin. Intermediate, 2 to 4 mm size, 2 centimeters is the margin. For thickness, the thickest, more than 4 mm, 2 centimeter margin is taken. More than 2 centimeter margin offers no survival benefit. Depth, excision vertically through the skin fat down to the muscular fascia. Routine excision of fascia itself is unnecessary. Closure, fusiform incision along relaxed skin tension lines or local rotation flaps or skin grafts is done. Special cases, subungual, amputation of distal interphalangeal joint, Mohs surgery, controversial for invasive melanoma, standard for in situ. The sentinel lymph node biopsy, it was introduced in 1992 and is a single most important prognostic factor for patients with no clinical evidence of nodal or distant spread. The melanoma diagnosis with intermediate and of thickness more than 1 mm, routine sentinel biopsy is offered if fit for general anesthesia. In thin melanomas less than or equal to 1 mm, which make up 70% of the cases, nodal risk is low, less than or equal to 5%. So, routine sentinel lymph node biopsy is not recommended. If high risk features are present, then the lymph node biopsy is done. The risk stratification is if T1 disease with ulceration is present, thickness of 0.8 to 1 mm with a mitotic rate of more than or equal to 1 mitosis per millimeter square. Younger patients paradoxically carry a higher risk of sentinel lymph node positivity. So, coming to the methods of lymph node tracing, the first is the preoperatively lymphoscintigraphy. Technetium-19 sulfur colloid is used. Its difficulty is that it must be injected 0.5 centimeters into the normal scale. Injecting too deep into subcutaneous place or into the tumor or the scar causes failure to map the lymphatics. Dynamic gamma imaging maps ambiguous drainage of the trunk, head and neck, identifying interval in transit nodes. In the intraoperative mapping, isosulfan methylene blue dye are injected intradermally just prior to the operation. The definition of the sentinel lymph node is resect if any apply. Visually blue, radioactive count is more than or equal to 10% of hottest node, palpably or visually suspicious. The permanent pathology is noted by the IHC. In immunohistochemistry markers S100, HMB45, melon A. Contraindications: immediate frozen section is avoided. Micrometastases are too difficult to detect. one frozen tissue. The trial impact timeline for the lymph nodes, sentinel lymph nodes, the MSLT1 trial and established sentinel lymph node biopsy as the standard staging tool showed that immediate complete lymph node dissection for sentinel lymph node positive patients improved 10-year disease-free survival but offered no overall survival benefit. The DCOG SLT and the MSLT2 trial evaluated positive sentinel lymph node patients randomized to complete lymph node dissection versus nodal observation on ultrasound confirmed no difference in overall survival or distance metastasis free survival. The modern standard of care, routine complete lymph node dissection, is no longer recommended for most sentinel lymph node positive patients. Why the shift? 5 out of 6 patients derived no overall survival benefit while risking severe surgical morbidity for 15 to 20% patients, rate of permanent lymphedema, paresthesia, and wound complications. The new standard, nodal ultrasound surveillance combined with modern systemic adjuvant therapies is being done. The therapeutic lymph node dissection, unlike complete lymph node dissection for micrometastasis, total lymph node dissection, therapeutic lymph node dissection is strictly required for macroscopic, clinically apparent regional nodal metastasis detected via palpable mass or abdominal imaging and confirmed by fine needle aspiration. The anatomical scope, axillary basin, inguinal basin and the cervical basin. Axillary basin comprehensive levels 1, 2 and 3 clearance requires clearing tissue along the axillary vein, thoracodorsal at the medial pectoral bundles and long thoracic nerve. Bulky disease may require dividing the pectoralis major. In the inguinal region, it clears superficial femoral nodes. If deep pelvic disease, multiple femoral nodes or a positive cloaquet node link beneath the inguinal ligament are present, a deep pelvic dissection, iliac or obturator is required. In the cervical region, functional neck dissection sparing the internal jugular vein and the spinal accessory nerve are done. Upfront systemic neoadjuvant therapy is now preferred. Full total lymph node dissection is increasingly reserved for macroscopic disease unresponsive to systemic treatment. The systemic and the targeted therapy. The modern systemic management relies on the targeted inhibitors and the immunotherapies. Comparing the different targeted inhibitors and the immunotherapies, the first one is targeted BRAF or the MFK inhibition, which targets approximately 50% of the harboring BRFA V600EK genes, and the key regimen is the Dobrafenib plus Tramitinib, and the study is the CombiAD. The outcome adjuvant 3, there is improved 5-year recurrence free survival to 52% versus 36% delays resistance compared to monotherapy. The anti-CTLA4 immunotherapy. The drug is ipilimumab and the study is EORTC 18071. It showed overall surveillance benefit but 54% experienced serious adverse events. Monotherapy largely dropped due to severe toxicity. The Amberacent, the anti-PD-1 immunotherapy, which is the standard, it comprises of the nivolumab and the pembrolizumab. The trials are the Checkmate 238, Keynote 716, Checkmate 76K. Nivolumab is safer, superior to ipilimumab, 50% versus the 39% 5-year recurrence-free survival is present, expanded use to high-risk stage 2B or the 2C. Personalized cancer vaccine, pembrolizumab plus mRNA 4157. Other drugs, the study is the Keynote 942, 18-month recurrence-free survival surged to 78.6 versus 62.2 with immunotherapy alone. The neoadjuvant therapy, delivering systemic therapy prior to surgical resection, is now the golden standard for clinically detectable stage 3 and 4 melanomas making it amenable to surgery. The SWOG 1801 studied on the pembrolizumab, upfront, surgery, adjuvant, total 18 doses, 3 doses of the neoadjuvant surgery followed by the 15 doses of the adjuvant are the administered. Massive improvement. The neoadjuvant approach achieved a 2-year event-free survival rate of 72% versus 49% for the upfront surgery. The opacin neo or the Prado, they studied the ipilimumab plus the nivolumab combination, the MPR concept, achieving a major pathological response in a single index lymph node allows surgeons to safely omit a full total lymph node dissection. Impact, it drastically lowers surgical morbidity and lymphedema rates without raising regional recurrence rates. The treatment or the management of the loco-regional recurrence and the in-transit disease. For the local regional melanoma recurrences, the local recurrence within 5 centimeters of the original wide local excision scar or graft. It is driven by aggressive biology managed via re-excision to negative margins. The in-transit disease, subcutaneous or cutaneous tumor nodules caught in lymphatic channels between primary and regional nodal basin. Intraregional oncolytic immunotherapy, TVEC, which stands for talmogene laherpaviriPEC. It has a dual action, works along with the oncolytic virus and the GMCS, that is the granulocyte macrophage colony stimulating factor. The mechanism is a genetically modified herpes simplex virus 1 is injected directly into the palpable lesion, which causes direct lysis and secretes granulocyte macrophage colony stimulating factors for systemic immunity. The Optim trial, durable response rate is 16% versus the control, which is 2%. The overall surveillance is 23 months versus the 19 months, the best for the stage 3B, 3C and M1A. The regional extremity chemotherapy, the salvage therapy, radiation and the metastastectomy. The adjuvant radiation therapy, melanoma is historically classified as relatively radioresistant. The indication is the post-lymphadenectomy, extranodal extension, more than or equal to 1 parotid node, more than or equal to 2 cervical or the axillary nodules, more than or equal to 3 inguinal nodes or a massive node of more than 4 centimeters and more than 3 centimeters in the neck. The study, the TROG 2.01, 48 gyre or 20 fractions cut regional field relapse from 36% to 21%. Medial cyan highlight but yielded no overall survival benefit. And the metastastectomy in stage 4 disease. The scenario is oligometastatic disease in highly selected patients with limited stable distant involvement. Example, a single resectable nodule. A complete resection yields 15 to 40% 5-year survival rates. The oligoprogression, that is the salvage. If widespread disease is under excellent systemic control but a single site fails to respond, resecting that isolated lesion, it extends the durability of the systemic regime. The adjuvant therapy, that is a treatment after the surgical resection. The targeted anti-adjuvant 12-month adjuvant is the dabrafenib and the tramitinib for resected stage 3 BRAF positive tumors. Improved 5-year relapse free survival to 52% versus the 36% of the placebo. The expansion to stage 2, expanded anti-PD-1 therapy to high risk stage 2B, 2C, thick ulcerated sentinel lymph node negative, profoundly reducing first recurrence and death. The immunotherapy adjuvant Checkmate 238 and the Keynote 054 study. The nivolumab and the pembrolizumab provide highly superior and significantly safer than the ipilimumab or the placebo, establishing anti-PD-1 as the undisputed standard for resected stage 3. The Horizon Keynote 942 intervention is personalized mRNA plus the cancer vaccine plus the pembrolizumab is administered. The result is improved 18-month recurrence-free survival versus the 62.2% with immunotherapy alone. The result was 78.6%. Compression chart, the targeted therapy, dabrafenib plus tramitinib. It is adjuvanted for resected stage 3 tumor. It must harbor the BRAF V600 mutation. The Combi AD study, 52% versus the 36% 5-year recurrence or the relapse-free survival is noted. Immunotherapy comprising the nivolumab or the pembrolizumab, adjuvant for resected stage 2B, 2C, 3 and 4. The studies are the Checkmate, Keynote. They outperform the ipilimumab or the placebo over with low toxicity. The combination therapy, the ipilimumab and the nivolumab, neoadjuvant for clinically detectable macroscopic stage 3. The Opacin and the Prado study showed high pathologic response allows omitting radical total lymph node dissection. The neoadjuvant monotherapy, the drug is the pembrolizumab. It upfront systemic therapy prior to definitive therapy. The SWOG 1801 upfront systemic blocks early micrometastasis. The 72% versus the 49% 2-year extracellular vesicles. The non-cutaneous subtypes, the uveal and mucosal melanoma. It arises from the neural crest cells that migrated to eyes or the mucosa. Distinct biology lacking a strong UV radiation signature. The uveal or the ocular melanoma, it originates in the retina or the uveal tract. It is the most common adult intraocular malignancy. It spreads completely, lacks lymphatics. Hematogenous spread is exclusive with extreme liver organotropism. Diffuse miliary pattern is noted. The systemic breakthrough, unresponsive to classic checkpoint inhibitors. Tebentafusp, bispecific GP100 peptide HLA directed CD3 T cell engager, is the first line standard for HLA 2:1 positive patients. 73% have the 1-year overall surveillance. Mucosal melanoma, its origin is in the head, neck, anorectum, female genitalia. The prognosis exceptionally poor due to occult anatomical location leading to late diagnosis. The surgical reality, radical wide excision is required, but extensive exenterations, example the pelvic exenteration, do not improve the overall survival. The unknown primary and pregnancy. The unknown primary melanoma, the prevalent, it accounts for up to 15% of stage 3-4 patients. The workup, exhaustive physical check of hidden surfaces, perianal, genitalia, scalp, nail buds, oral cavity, nasopharynx, with mandatory brain MRI and PET or CT. The prognosis paradox. Overall survival is equal to or slightly better than stage-matched patients with known primaries. Hypothesized to reflect a robust spontaneous host immune response that destroys the original tumor. Melanoma and pregnancy, prognosis is identical to non-pregnant pairs. Hormones do not accelerate disease. The surgical safety is wide local excision is safe under local anesthesia. The sentinel lymph node biopsy, technetium 99 is safe. The vital blue dyes must be avoided strictly. 1 in 10,000 have the risk of severe maternal anaphylaxis. Timing, deferred pregnancy for 2 to 3 years post resection. Highest risk window for recurrence. Surveillance and salvage, metastastectomy, surveillance timelines, low risk, stage 0 to 2A, every 6 months for 3 years, History and skin exam. Annually take history and the skin exam. Cross-sectional imaging, CT or PET, is to be done. In high risk, stage 2B and 3 and 4, follow-up to be done for every 3 to 4 months for 3 years. History and skin examination is done. Every 6 months, the history and examination followed by cross-sectional imaging, PT or SET, is routinely incorporated to detect asymptomatic low volume recurrence. The survivorship facts: survivors carry a tenfold increased risk, 5% lifetime, of a second primary cutaneous melanoma. Lifelong full body checks are mandatory. Metastastectomy guidelines: stage 4, oligometastatic disease, complete surgical resection of a single stable distant organ nodule affords a distinct survival advantage, yielding 15 to 40% of the 5-year overall survival. And the oligoprogression: resecting a single non-responding lesion in a patient with otherwise well-controlled systemic disease can significantly extend durability of the immunotherapy. The management matrix: path 1, high-risk microscopic disease, stage 2B 2C, thick ulcerated SLN negative, or stage 3 via positive SLN. First line standard: adjuvant anti-PD-1, that is nivolumab or the pembrolizumab, adjuvant BRAF MEK inhibitor if BRAF V600 positive. Approximately 50% would never recur without therapy. Better risk stratification markers are actively researched. Pathway 2, it is clinically detectable or resectable, palpable or radiographic regional nodes, local recurrence, resectable. Stage 4, the first line standard treatment is upfront systemic neoadjuvant therapy before surgery, intralesional TVEC for rapid cutaneous recurrences. Path 3 is unresectable metastatic, stage 3 or 4. The target is distant visceral and the CNS spread. The first line standard is combination checkpoint immunotherapy or combination BRAF and MEK inhibitors, guided by function, comorbidities and mutation profile. Thank you. I hope that was useful.